Hello, everyone. My name is Dr. Richard Horowitz, and I'm the co-host of the Dr. Talk Healing Lyme Summit 2.0. It is my great pleasure to introduce to you a long-term friend of mine, Lorraine Johnson. Lorraine is CEO of LymeDisease.org and principal investigator of My Lyme Data. And we're going to discuss today the My Lyme Data, which is the largest at this point, internationally, nationally driven registry for patients, talking about how they do with treatments, outcomes. Lorraine, thank you for joining us today. It's going to be, I know, a fascinating conversation.
It's my pleasure, Rich.
Yeah.
I want to add a few things about my background that I think most people won't know. And one is that I am a recovered patient who had persistent Lyme disease. So I was one of those people who was misdiagnosed for 5 years and then ended up on some fairly aggressive long-term treatment to get well. And the other is that my background is that I'm an attorney who has an MBA. So when I became involved with Lyme disease, I started getting involved in healthcare policy matters and started working with national government organizations like the Patient-Centered Outcomes Research Institute, the Cochrane Collaboration. So a lot of, sort of high-level government positions. And I learned quite a bit about that, about how the healthcare policy arena works and what was needed for us to do in Lyme disease.
Yeah, no, that's great. So tell me, what inspired the creation of My Lyme Data and what are the primary goals? How did you get into this?
Well, the main thing that inspired my Lyme data, aside from the fact that I was working for the Patient-Centered, Research Outcomes Institute, and their focus was on patient registries. So I actually was on their executive committee overseeing, the patient registries there. So I learned a phenomenal amount about patient registries, but it was clear that we're at this time in history where the patient voice can actually matter in terms of research. It didn't used to matter much. It used to just be researchers in a lab. But there were more and more patient registries being put together. And a lot of them were put together by rare diseases because nobody had done the research. But in Lyme disease, it's not the problem that we're a rare disease. The problem is that nobody was doing the research. So we had this 20-year gap where nobody was really looking uh, at research projects. It's 25 years now, I think. So the last NIH project was over 20 years ago. And it was really clear that patients don't need to wait. Patients can't wait and they don't need to wait in order to have some research going on that's really important and to be building a knowledge base. So those were really sort of the primary reasons that we got involved with putting together the registry.
Right. So you're bridging this critical gap between patient experience and scientific research, which really doesn't get done. And you have over 18,000, did I get the number right? People
Right.
who've now registered.
Yeah, and what's interesting about that, Rich, is academic research is typically top-down driven. So they're going to have entry criteria that's going to exclude a lot of patients. And when you do that, you're not dealing with real-world data. You're not dealing with the type of patients that a clinician will see in their practice. And so these are the patients who are misdiagnosed or that have co-infections or that had a delayed diagnosis. So bridging this gap between academic research and what patients' experience is, which, by the way, is the same thing as bridging the gap between academic research and clinicians, because the patient experience reflects the clinical experience, of course, right?
Right, of
So
course.
you're able to just sort of leapfrog over and gather a lot of data that you just couldn't get in any of these, government-funded trials.
Right. And so, for example, if the prior NIH trials didn't really show that, well, there actually was some benefit with antibiotics in the Krupp
Right.
study with fatigue and Bryan's study with neurological symptoms. But if the word on the street through the NIH was there's really no sense in giving longer term antibiotics, right? They don't work. But then we come to your registry and we read it, it's like patients kind of say actually the opposite, right? As far as what they're reporting.
Yeah, I mean, it's over 50% are having a treatment response that's either they got well or they improved, significantly or they improved mildly. So these are all people who are on their diagnostic journey and treatment journey. So it's not a point in time study where, somebody's had just 30 days of treatment. And of course, we're including long-term outcomes, right? Which I think is the really critical piece. So, like in our registry, what we found was that the people who did really well, those were patients who had been on antibiotics. They'd been on them for a long time. Uh, that means over 4 months. We don't have any trials that are over 4 months. And most of them had been on them for over a year. So if you're looking at what is it that makes a patient get well, the factors were antibiotics, long-term, and working with a clinician who specializes in tick-borne diseases. Those were going to be the factors that were going to be predictive of whether patients got well.
Right. And of course, what I'm trying to prove, and I know you know this, I'm in the
Yeah.
process of trying to apply for a multi-center placebo-controlled randomized trial of dapsone combination therapy, which is less than 4 months. And in fact, it's a 8 to 9 week oral generic protocol, no IV, but also looking at overlapping factors of inflammation. So what I'm hoping to prove, right, is that the reason these people have needed longer term antibiotics to stay well is the older treatments that were done in these old NIH studies. They were not looking at the biofilm persistiforms of Borrelia burgdorferi. They were not addressing Bartonella, which also has Bartonella biofilm persistiforms. They weren't addressing POTS dysautonomia, viruses, right? Long COVID wasn't around. We're finding all these overlapping factors keeping people sick. Now, in the registry, are people kind of listing these things that they're finding that are overlapping that are causing them to be ill?
Oh yeah, I mean, we gather information about, the number of patients who've got co-infections, and that's that's about 70% or higher than 70%. So
Right.
76% are reporting co-infections, and the major ones are Babesia and Bartonella. So those are both over 40%. And a lot of patients are reporting two or more. So if you have clinical trials that exclude everybody who has a co-infection, which the clinical trials have done, you're not going to get a sample. See, one of the things that may predict who develops persistent Lyme disease may be these co-infections. So you
Mhm.
leave all of these people out, and you're not going to get any of the data back that reflects how those people are doing.
Yeah, I mean, this is the problem we face is we can't avoid it. I mean, in my patient population, I mean, it's at least 80, 90% have Babesia Bartonella and overlapping factors. The
Yeah.
problem, of course, when I try and get this trial going is almost everyone's going to be exposed with Babesia titers or an immunoblot or Babesia or Bartonella immunoblots titers. But I hope to have fish negative, meaning they're not active. And that's going to be, I think, the only way I'm going to be able to enroll people because I don't think you can exclude people at this point. When we call it chronic Lyme, the reason I like calling it Lyme MSIDS is I'm referring to the fact that it's Lyme with all these overlapping co-infections and mold toxins and POTS and all these variables, right, that are keeping them ill.
One thing you might consider, which is if you're looking at co-infections, is to do subgroups. So you may have us, we ask the simple question, have you been diagnosed with a co-infection? And then we ask with supporting labs, without supporting labs. So we do it that way. But you can take the people who are not your positives and put them in a subgroup and see, is there really any difference in these people? Because it's sort of a way of looking at how valuable is clinical diagnosis with these co-infections. And I think sometimes it's extremely valuable. Do you have night sweats? Do you have a lot of neurological symptoms? Are you having psychiatric symptoms? Those are really, clues that that patient may have a co-infection.
Right. Yeah. So no, I agree, and that's of course what's showing up in our practice also. So the patients that have enrolled in this registry, how does chronic Lyme disease compare to these other chronic diseases that are out there like CFS, ME, and fibro? How chronic congestive heart failure is the one that people usually talk about that are
Yeah.
sick. How does it compare?
Well, it's much more severe than most illnesses. I think 77%, this is such an important question. How would you, in general, how would you rate your health status? Excellent, very good, good, fair, poor. So 77% of patients in our registry say that they have fair or poor health status. And that's a really large number. You don't see that type of number ordinarily. The general population has got 16%, reporting fair or poor health status. And the impact on patients' life using that question, because it's a government question and it's been used across multiple diseases where it's been compared, we see that Lyme patients have a far worse quality of life than patients with CFS, patients with fibromyalgia, patients with congestive heart failure. So it's an extremely debilitating disease. And, aside from that, the other place you see a really big impact is on people's ability to work. So that's a really blunt instrument. Can you work or not? I mean, usually you don't walk into a doctor and they say, "Hi, can you work?" If you can't work, you're really in trouble. Yeah.
What,
So we have
what
like,
did, Lorraine, what were the disability rates? What were the disability rates that you found on the average in this population?
It was 25%, and that's been pretty consistent over a number of studies that we've done, 25%. And approximately 40% say that they have either had to reduce their hours or adjust the type of work they do. So maybe they're working at home, right? So remote
Right.
work. And, people don't necessarily think of those factors. I mean, you might ask somebody, what has your activity level been the last 2 weeks or 1 month? And that may not reflect how the disease has impacted them because maybe 2 years ago they had to quit their job.
Mhm.
And that's not going to be captured in that 2 year period. And they may still be not working. So you have to actually, if you're looking at things like limitations on function, you have to actually look at what's happened to the patient over the course of their illness. Are they dealing from a place of a new normal? Have they now decided that it's normal not to work? Have they now decided that it's normal to work part-time or it's normal to have to work at home? So those are factors that a lot of researchers aren't looking at, and it's an important factor.
Mhm. And what are the most common severe symptoms you're seeing in this patient population?
Well, the most common is, fatigue, of course.
Right.
But then we have sleep impairment, muscle aches, joint pains. But the ones that you see gathering together are the neurologic symptoms. And there it's about 84% identify as having neurological uh, symptoms as among their three worst symptoms. So that's another question we ask. What are your three worst symptoms, right? Because that's a telling question. Somebody might have severe psychiatric symptoms, but those aren't their three worst. They're going to tell you their three worst or something else. So
Mhm.
you really have to, look at these measurements of symptoms differently, I think, in order to capture the information you need.
Right. So fatigue is there, but of course, cognition, brain fog, neuropathy. When you collect the data on neuropathy, tingling, numbness, burning, stabbing
Yeah.
sensations, one of the things we found when we validated our questionnaire years ago with State University of New Paltz researchers is that it migrated. Are you collecting it all the migratory aspect? Is that being asked, or it's not specific? Because even Alan Steer was finding it early on, and early Lyme, and we see it quite a bit in our patients.
Yeah. You have one of the things you have the benefit of is you have the benefit as a clinician of having longitudinal data. And
Yes.
our data is a point in time data. So we gather a really vast array of data, but it's on a single point in time. So we're not seeing those fluctuations, but we do ask patients whether they vary, and the answer is yes.
Okay. So how does my Lyme data is different from the traditional clinical research approach? Like, explain again, like why, and again, for people listening, I'm speaking to Lorraine Johnson, who's CEO of LymeDisease.org. When we've done our prior podcasts, by the way, I've encouraged people to please sign up. If you are a Lyme patient and has not at this point contacted Lorraine and my Lyme data, and Lorraine, tell them how they can do this, because really everyone who is suffering from this really should be in your registry at this point, because the more people that register, the more information we're getting, the better, obviously, we can diagnose and treat patients. How are they
Right.
going to sign up for this?
So you go to mylymedata.org and you simply input your information. It's not a long process. It's something that almost any patient can do. I mean, a lot of patients can't work, but they can do this. And it just contributes so much to the body of knowledge that we have. So I think it's really important if you or somebody you know has Lyme disease, please join up for My Lyme Data at mylymedata.org.
Great. And again, how does this vary exactly from the traditional clinical research approaches that have been done before?
Well, it's really interesting, Rich, because you know, it came at a time when big data was just emerging as a type of research that you would do, right? But big data is new. It's an emerging type of research.
Mhm.
And so it goes, the people who are doing big data research are typically very different from those who are doing traditional randomized controlled trials. Traditional randomized controlled trials weed out a lot of patients, and then they look on a single variable, like maybe it's one treatment and it's for a course of time, and that's it. It was either successful or it wasn't successful, and it took 5 years, by the way, to do this study, and it cost a gazillion dollars, right? And the results aren't applicable to most patients. So, the critique of traditional research is it costs too much, takes too long, and doesn't apply to most patients. When you're excluding, and the NIH studies excluded between, I believe it was 93 and 98% of patients. When you're excluding that many patients, what is it that you're studying? You're not studying patients who have Lyme disease. You're studying something. It may be important to someone, but it's not important to most patients, and it doesn't apply to clinical practice. And it's such a big problem that we actually did a study that's pending publication right now, actually. And it is taking a look at the patients who are clinically diagnosed. So you start with 100% of the patients who are clinically diagnosed. And then you say, what is the effect of a positive Western blot or a rash positive, or, history of a rash? What is the effect of co-infections? What is the effect of having a prior diagnosis of CFS, FMS, or a psychiatric condition, right? Because those are all exclusions in the standard, protocols for randomized controlled trials. And what you find is that when you go through this list, it's a short list. It's just four, we just looked at 4 items. You end up with a sample size that's just, not, it's 10%. It's like you've excluded 90% of the patients by applying these, generally used standards. So it's not that we don't need standards. We need standards, but we need to be very careful about which standards we're using and why. And a good example of this is, if you're going to exclude patients who have been previously diagnosed with CFS, FMS, or psychiatric conditions, that's about 53% of patients who've been clinically diagnosed. Okay, that one requirement is about 53% because those patients were misdiagnosed.
Mhm.
So most patients before they're diagnosed with Lyme disease are misdiagnosed with another condition, and the most common ones are CFS, FMS, and a psychiatric condition.
Sure.
So, you're not gathering the information that you need in order to be able to, to make valid conclusions that apply to clinical practice.
And
And I just want to say one more thing. I just
yeah,
really encourage, when this study is published, I really encourage clinicians, researchers, anybody who's doing research, take a look at the effect of each exclusion criteria before you apply it. And ask yourself, is this scientifically justified? Do I have a good reason for excluding patients who had a prior misdiagnosis? I mean, I don't think so. I think that's an error that
no,
occurred.
and in fact, in designing the randomized trial I'm trying to do right now,
Yeah,
I never thought of excluding these people because, just as you said, the majority of people who come to see me who end up with the diagnosis of chronic Lyme, PTLDS, and all these overlapping
yeah,
factors,
right.
they have a chronic fatiguing musculoskeletal cardiopulmonary neuropsychiatric illness, but
Yeah,
the symptoms of chronic fatigue, ME, fibro, long COVID, and chronic Lyme are basically all the same, right? With
mhm,
fatigue and pain and neuropathy, and I can't sleep, and I have POTS dysautonomia and
yeah,
psychiatric issue. The symptoms overlap. I mean, the only difference I see with Lyme is the symptoms come and go. Good and bad days, or it migrates with the pain, which is the hallmark of Lyme, which you don't necessarily see in long COVID. But from what I'm getting from Bruce Patterson and other people in long COVID, they're going to
mhm,
find that a lot of these long COVID patients have Lyme and Bartonella, as well as mold and everything else overlapping. You can't exclude, it's a mishmash at this point in time to think that you're going to live in a bubble and just
mhm.
find pure Lyme disease. You have to take patients in the real world
Right.
with these conditions and see, this is
Yeah,
what I'm trying to do,
yeah,
apply the model, how many of these 16 factors are theoretically keeping them ill, adjust them,
Uh-huh.
give them dapsone, and then follow them over time. And so I'm not planning on excluding them. I just have to figure out how to exclude active Babesia bart, because otherwise it's going to get a little bit tricky trying to prove the efficacy of dapsone for chronic Lyme. But ultimately, we may have to have secondary, pulse effects afterwards or using other things. We'll have to figure out how to do it down the line.
Well, I mean, with Dapsone, do you give it to your Bartonella patients?
Oh, yeah. In fact, the thing about
Okay, so
Bartonella.
why are you going to exclude them?
Well,
Exactly.
no, but the reason is because if they have like Lee, my beloved wife is now 6 years
Yeah,
in full remission from
yeah,
dapsone combination therapy, but
right.
she tested positive for BART, but she wasn't active when she finally did double
Uh-huh.
dose dapsone. The problem
Okay.
with BART is if people do the 9 week protocol and the
Yeah,
BART is active, and
right.
I've addressed mold and I'm pulling the toxins and
Yeah,
POTS and
right,
low
right.
adrenal, I have to give them pulses of dapsone, roughly 2 week pulses every 2 months, at least 4 pulses over a year. So that would mean extending the trial to
Oh, I
1 to
see.
2 years with
Okay, so now,
1 year follow up.
yeah, right, right.
It's a
It's
much
cost.
longer follow up.
Yeah, it's cost. It's cost. Well, I mean, and cost is an important factor because you don't want the perfect to be the enemy of the good.
Yeah.
You know, you actually just want to get some of this stuff done. It's just really important.
Yeah. So getting back to what we've learned so far from the My Lyme data
Yeah.
about persistent Lyme disease, what have we learned so far from this that we didn't know from the traditional research?
Well, okay. I think that some of the most important things that we've learned are how patients vary, how different they are. All of the NIH studies assumed that patients were a monolith. I mean, they used treatment averages. They didn't have a large enough sample to say, okay, well, these people, were had co-infections, or they weren't able to actually parse out the data. So you ended up with a mishmash. If you look at it this way, Rich, if one person tests negative, and that's a negative one, and one person tests positive, and that's a positive one, and now you average them together, you get zero. So it's not useful information. It's you want to be able to actually know how patients vary. So one of the studies we published was on treatment heterogeneity. It was on how patients varied in their treatment response. That's a really important study because it shows that patients are not all the same, that you actually have to look at these different subgroups. And, if you have a large enough sample, you can look at subgroups, but you can't do it with a really small clinical trial. So
Right.
that's one of the things. And the other thing is we learned that patients really vary in how they respond to treatment. It used to be that what you heard was that everybody's on IV antibiotics. Well, that's not true. I mean, I think it's something like 2% are on IV antibiotics. But if you listen to the CDC and the NIH, you're going to believe, well, everybody's on IV antibiotics, and we have to do everything we can to shut down treatment. I mean, the fact of the matter is, of the patients being treated, almost all, are being treated on common oral antibiotics.
Yes.
So that's another thing that we were able to discover that wasn't known before. Symptom severity. So you say, does a person have a symptom or not? We started asking, how severe are your symptoms? That will really distinguish between the general population that's got an itsy bitsy little bit of fatigue and the Lyme population that can't get out of bed, right? You
Right.
have to ask about severity. So if you're really focused on your patient population and you understand what's driving this disease, you're able to get it information that isn't known. And the other thing we're doing is we're kind of completely blowing up the house of cards that the only way to do research is traditional randomized controlled trials. It's one way to do research, but it's not the only way to do research. And so you need to be bringing together all of these different types of ways of approaching research.
Yeah, and we talked about it a little bit before we came on today. It's like since I plan on enrolling hopefully a couple of hundred people in this trial, I'll make
Mhm.
sure also that we connect with my Lyme data so that they're feeding it in, and maybe you can even do a subgroup analysis to see because you've got AI running. I mean, you even have one AI, or it's like several AIs running to do subgroup analysis of the
Yeah.
data at this point, right?
Well, I mean, we're working with UCLA. So, if you're working with a professor, Professor Deanna Needell, who is, by the way, fabulous, and who joined in our efforts the very first day we started. It was kind of remarkable. She gave me a phone call, I want to be in. So we've been working with AI for a long time. We've learned an enormous amount about working with AI. And it's so fortunate that we've developed all of our protocols and how we analyze data in step with AI, because you actually need AI to start sifting through vast quantities of data.
Right.
There just isn't any substitute. You can't do it manually, one calculation at a time. Or
Sure.
I think it's this. I think this is the important thing. And then you do that analysis and you find out, oh, that wasn't the important thing. AI can tell you, look at these 5 factors. And so the most important thing, Rich, in putting together that type of study for where you're going to be using some subgroups, is to make sure that you ask the right questions for identifying the subgroups. And it would be lovely if you were asking some of the same questions that we were, so that we had comparable.
Oh, I will definitely speak to my statistician.
Yeah.
Her name is Nicole.
Uh,
Nicole Close is the one we're going to be using. She's done multiple randomized trials. I will make sure I put Nicole in touch with you so that when we eventually start collecting the data, she can use, I mean, your extensive experience here.
yeah.
Obviously, we want to learn from what's already been done and not have to, reinvent the wheel at this point in time.
Yeah, I mean, it's interesting too. I mean, the other thing that I think is a really huge accomplishment for my Lyme data is we're now on like our 8th publication, our
Mhm.
8th peer-reviewed publication. It's extremely uncommon to have patient-led research to begin with, and then to have that many publications in coordination and partnership with academic researchers, biostatisticians. It's really remarkable, and it's changed, I think, the way we look at research.
Well, I mean, we're in the middle of a worldwide epidemic. I mean, somebody's got to care at some point in time with everybody doing this. I mean, even if it wasn't compassion, the place where you were coming from is, oh my God, we have to get sick people better. They would do it for financial reasons alone because of the disability rates and, all right, insurance costs and everything
Mhm.
that's happening associated with it.
Yeah, yeah, it's a big deal. And the point that you were making earlier about co-infections and about how a lot of these symptoms overlap. I'm not sure you're aware of the efforts of, infection-associated chronic conditions and illnesses. IACI is kind of the moniker that it's used, but the National Academy of Science and Engineering and Medicine hosted a workshop, which I was fortunate enough to be on the planning committee for. And it brought together all of these diseases at the same time. And so, for the first time I have ever seen, we had clinicians who treated each of these individual diseases, researchers who treated these individual diseases, and they were talking to each other. And you were seeing the symptom overlap. And you were seeing that some of the mechanisms that might be at play, there could be commonalities there, and that it was important to understand how these diseases were working in general, where they overlap, and then also to do individual research where it makes sense. So,
Yeah.
I mean, I had somebody ask me, have you asked people in my Lyme data whether they have, COVID or long COVID? And we haven't yet, but we will. But even if you did, it's kind of like almost everybody has had it. So, I mean, is it a factor that's going to distinguish? How small is that population going to be that didn't? You know,
Yeah, and it's a little tricky with long COVID because of the definition of long COVID and whether you want to use, for example, Radiance Diagnostics and Bruce Patterson's 14 cytokine panel to
yeah,
meet the official criteria. It gets a little bit tricky, but
yeah,
certainly if you've had COVID, you're much worse, which we've seen, of course, happen to patients. And we started using a little bit of Pravastatin and Maraviroc to see. We're still
yeah,
evaluating it. The only part I have difficulty, I think it's great that all these people are coming together for
yeah,
different diseases. And by the way,
yeah.
so my third science book, I don't know if you know I'm writing this, but Simon and Schuster gave me a contract. My third science book I'm writing is on
Mhm.
why we stay sick. And what I found is when I did an AI dive into all these major diseases from autism, ALS,
Mhm.
Alzheimer's disease,
Yeah,
allergies, cardiovascular, it doesn't matter what the name of the disease is, cancer, All 16 points on the MSIDS model are showing up in the medical literature on a PubMed search. The only problem I have with associated infection chronic illness of calling it that is that there's, of course, been this problem in the Lyme community for a long time that they don't like calling it chronic Lyme disease, or some people don't like PTLDS. I don't mind chronic Lyme disease because it is a chronic infection, but I prefer Lyme MSIDS or non-Lyme MSIDS only because the 16 points on the MSIDS model are showing up in chronic fatigue syndrome, in fibromyalgia, in Lyme, in long COVID. The article we published this year, all 16 factors on the MSIDS model that I published in 2018 in healthcare showed up in long COVID before the virus was even around.
Yeah.
We need a common denominator. All these chronic diseases, you probably know this, but roughly 1 in 2 Americans suffers from a chronic illness, right? And if you add up long COVID and CFS-ME, you're talking over 14% of the US population. It's a big problem. So I'm glad the researchers got together. I just wish that they would at least take some of the research we have done and look at it. Maybe after the book is out, it'll get a little bit more traction of using the model we're using, because the PubMed search shows up in all of these different chronic diseases.
Yeah. I mean, it's interesting because, just terminology or definitions of a disease, right? I mean, that's interesting. I don't know. I mean, I think CFS is 10 different definitions have been developed for CFS. And so which one are you going to use
Yes.
becomes an issue, right? And so, the thing with chronic Lyme is it is chronic Lyme. You can, everybody knows that from 30 years ago, right? The CDC, when they're doing a survey, they say chronic Lyme. And you ask them, well, why do you do that? As they explained it in one of their papers. And the reason they do that is they say, this is what the public knows the disease as. So you've got to reach people in both places. One way, you have to have people understand the similarities and the overlapping nature of these diseases. And on the other hand, you have to have people be able to understand this is what we're talking about in common language, right?
But by the way, when you're doing these subgroup analyses, and I don't know if you've looked at this, have you looked at any of the persister drugs like rifampin, methylene blue? Have you been able to, or can it be done eventually with AI to look at these subgroups to see how these
Yeah.
people who've used persister medications do compared to the other group?
Yeah, I think the question is, it's really interesting. You have this really large sample, and then that sample, 52% are taking antibiotics. So now you've eliminated just about 50%, right? And now you're looking at what antibiotics are they using. And the primary antibiotic, I'm going to just let you tell me what the primary antibiotic is that's used to treat Lyme, because it's the one that shows up in, like, I don't know, 90%. Say 90% of people are doxycycline is what
Yes.
they're answering, right? And then you get down to some of the other more common IV Rocephin. But eventually you make your way down to methylene blue, and you make your way down to dapsone. And we've got people who've tried dapsone who are in our registry, and people who've done methylene blue. We don't have large numbers. So I'd love to see 100 people or more that have tried one of those, one of those drugs. And that's why we need more people to sign up and enroll in my
You know what I think I'm doing now that we're having this conversation?
Yeah,
I'll speak to Heather from my office
yeah.
to actually see if we can blast out and tell them at this point
Oh,
that,
that'd be great.
yeah, because these are all people in my
Yeah,
practice that have used it, right?
yeah.
And maybe if enough people sign up, you can do a subgroup analysis with the AI.
Yeah, that's right. That's right.
Yeah.
I mean, this thing about working with clinicians, Rich, it's so important because clinicians have so much to offer. And the registry has a lot to offer, but the two together really can make, I think, big progress.
Mhm. Yeah. What is there something really surprising that came out of the data? I mean, most of us expected chronic fatigue and neurological issues, of course, to be there. For those of us like myself in there, I'm not surprised that longer term antibiotics help people, because people would come in to see me and say, I stopped them, my symptoms came back before I started using more of the persister drug regimens. Was there anything surprising that came out of the data you weren't expecting?
Well, I'll tell you that I have been completely floored by how much variation there is in the
It's
disease.
the variation.
Yeah, how much variation there is in the symptoms that people present with, how much, even if you look at, gender, you see that there's huge differences in males and females with this disease. And, we published a paper on biological sex-based differences in Lyme disease. And there was some research that was done before it, and there's some more research that's being done now at Johns Hopkins. So, a part of this is getting conversations going about topics nobody's talked about,
Mhm.
in a robust way. But that's, all of that variation and the variation in treatment response, I think are really extraordinary in this population, particularly considering that we were told that everybody was the same, that they all had a Western blot, that they all had the rash, that they were all treated timely. None of that stuff is true.
And the variation in treatment responses, at least what we find, is
Uh-huh.
that people, for example, have mold toxicity. They
Right.
don't respond to the treatment as well. And whether it's because the mold toxins themselves cause similar symptoms of fatigue, brain fog,
Right.
neuropathy, or because the gliotoxins are suppressing the immune system, or all of the above, we're finding there are certain specific key factors like mold, long COVID, horrible POTS dysautonomia affecting your fatigue, your dizziness, your brain fog. I mean, some of these are well known, but we're seeing these factors like if we don't address these overlapping factors of inflammation and downstream effects, the effect that we're seeing from our 9-week dapsone protocol and pulsing, it's not going to be as robust because it's like going into a doctor's office with 16 nails in your foot. You pulled out one nail and you still got 15 to go, right?
Right.
So
Right.
are you able to see in the subgroup analysis this same type of thing? Or again, it's not yet been completely looked at?
Well, we ask the questions about mold and pots, but
Hmm.
we haven't turned our resources to developing that or taking a closer look at it, but we will. I mean, I have a question for you. When you treat the patients that you have that have POTS with dapsone, do you believe that the dapsone has an effect on the POTS?
No, not specifically.
Yeah, okay, that's interesting.
No. And as an example, my wife has no more chronic Lyme symptoms, but she still has some residual POTS, but that's from kind of limbic vagal issues from trauma as a child, the vagus nerve being affected. No, we find I have over 50% of my patients are doing vagal limbic retraining because the limbic system, a lot of them have been abused in many different ways. The vagus nerve gets affected by mold, by Lyme, by BART, by long COVID. We
Yeah.
find we have to do vagal retraining and limbic retraining. Otherwise, we don't get the same robust responses. So, no, the dapsone will help with layers of fatigue and brain fog and pain and neuropathy. But if your fatigue and your brain fog is due to POTS and you're not treating the POTS properly or getting to the cause of it, you still might see that the fatigue and brain fog is somewhat better, but
Yeah.
you're not going to get the full result of the protocol until the POTS has been addressed.
Okay, I have another question for you.
Yeah.
So, what is vagal limbic retraining? Everybody's going to want to know, Rich.
So the autonomic nervous system, the part of your body that does the
Yeah.
involuntary movements of breathing and heart rate and digestion and moving your bowels, and this is the autonomic nervous system. It's kind of the silent part of your nervous system that's not volitional. It's in the background and it's doing all of what it needs to do. So there's two branches: the parasympathetic, which uses primarily the vagus nerve. Vagus
Mhm.
nerve is has a big role actually in inflammation, but
Mhm.
if the people who, for example, come in that are very anxious, they have
Mhm.
the parasympathetic is kind of decreased. They have an orthosympathetic increase where they have fight or flight reactions. They're putting out epinephrine and norepinephrine. In those patients, they're not easy to get better because of this imbalance in their autonomic nervous system. So we
Right.
find that between the emotional trauma that they've had in the past, either from being gaslighted, going to 30 doctors telling them there's nothing wrong with
Yeah.
them,
Right.
or for abuse earlier in life, or because they've actually had mold or other factors making them ill, we find that getting their autonomic nervous system back in balance, meaning you're not overstimulated with your orthosympathetic fight or flight or too
Mhm.
much parasympathetic, it's got to be in balance, right, for the body to work properly. When
Right.
that happens, we find people feel much, much better. So there are techniques. Some are like meditation techniques. Some people wear like these devices on their wrists, like the Apollo NeuroStim is one that people love. In fact, I just ordered one for Lee and a friend of ours. I'm even going to try it myself to see what it is. I'm getting some great results from patients doing these things because they don't always have time to meditate and do some of these techniques like the anti-hopper dynamic neural retraining, the Gupter amygdala insula retraining, primal trust. There are all these techniques that work. They do a great job. but you got to stick with them for a half hour, hour a day, and it takes months. So people are
Or years,
accessing these
or
things,
years.
but it takes time to do the healing. But I can tell you, the reason it's important in people is when you look at the 16-point MSIDS model from my perspective, mitochondrial dysfunction, where you've got all this free radical oxidative stress and inflammation damaging the cells in the joints,
Yeah.
the mitochondria get stuck in what's called a cell danger response. So if you are in an unsafe environment, if you're in California and you have frequent wildfires or floods or mudslides, your system is in a state that no matter how many antibiotics you take or how much mold detox you take, you're not going to go back in balance and you're not going to be well because the mitochondria is getting stuck in this cell danger response. The limbic retraining, by addressing mold and addressing Lyme and co-infections and POTS and doing all this, and then doing the limbic vagal retraining, it kind of resets the system so the healing can then take place. And we really see for some people, absolutely essential, especially the people that have had abuse and have been gaslighted before coming to see us. Like that, the mind-body connection. I mean, you really see the results of it. That you can't just give them antibiotics and treat. You've got to really do all of this to get patients better.
I think it's so important. I know you recently did an article on that mentions meditation, as one of the things that's important for patients to be involved in. The other thing I just wanted to mention that's really striking about what you said is, you know, the innovation aspect of your patients coming to you and say, we're using the Apollo, neurostem, and so now you're saying, okay, I'm wondering about the Apollo neurostim. Maybe I should look at that. Maybe that's actually something I should be using with my patients, right? But there's this piece of innovation that gets lost when you're just doing top-down academic research. It's
Mhm.
the innovation piece. And the people who know the innovation are the clinicians and the patients. And that's what we need to be capturing. So I'm really glad to hear, that you're moving in those types of directions.
Well, I mean, whatever innovation I've had comes from the great researchers, because if John Hopkins researchers like Dr.
Yeah,
Ying Zhang had not talked about biofilm persistent
that's
forms of the
true. No,
bacteria,
that's true.
I wouldn't have said, oh, hold on. Oh, you
Yeah,
mean persistent bacteria like TB? Oh, maybe I should look at mycobacterium drugs for leprosy and TB. And then I used them and went, oh my God, home run out of the park. It's
yeah,
because of them. It's the innovation really came from just reading the literature. And thank
yeah,
God the Lyme groups were funding Hopkins
yeah.
and Stanford and Eva Shoppe's group. And
Oh, no, all of that research is so important. It's
yeah,
so important. Yeah. I mean, I say this thing about the academic model, but I don't really I don't really mean it as a broad sweeping thing, because the fact of the matter is, like you point out, we've had some terrific research that's come out in the last, particularly the last 5 years, I'd say.
yeah.
And it's just one way that we need to be thinking about this is we need to be thinking about how do we capture innovation? How do we capture innovation of patients who've been told they can't do this or they can't do that or they don't have access to this? You need to be able to capture that innovation because it's what informs what we can do.
Right. And the gold standard of medicine is a randomized multi-center placebo trial, which is why I'm now
Yeah,
right? Because even
yeah,
though I know it's working, the rest
yeah.
of the world's not going to know until I prove it in that model.
Yeah, right. Well, I'm really grateful that you're going to do that,
Yeah,
Rich. I think it's such an important thing to do. A lot of people do things that they think work and they don't put it to the test.
yeah,
But you're walking the walk in terms of here's what I believe and here's what we're going to do to demonstrate it. I
yeah,
think that's so important.
yeah. Now, in our group, of course, I mean, we see, and this is the reason I'm doing the study, is we see superior results using persistent drugs and biofilm agents. In your group, when you're looking at the My Lyme data, are
Mhm.
you able to tell why some patients respond differently to antibiotics, like why some do better and some don't? Is the subgroup analysis able to show that at this point?
We're not looking at biological data. So we're not able to actually say, okay, was there a persister there? What we're able to do is we're able to say, what seems to be working for people. And that's like a really in-depth analysis that needs to be done. I'm waiting for there to be a larger sample in things like dapsone and methylene blue. Some of the more, recent treatments that I think may be really making a difference so that we can actually take a look at, the population as a whole. But a lot of times, if you ask a patient, what medication they're taking, it's going to be doxycycline because that's what their physician is prescribing, either because it's the first step in their treatment journey or because that's all their physician prescribes.
Mhm.
And, they may be taking it for a longer term or shorter term. But the
Right.
persister issue is a really big issue. I don't think we can get at that through the survey data. I think
No,
that's going to have to come from clinicians who can, look at
no, and
the,
I realize now speaking to you, I really need to tell Heather from my office to send out a blast. In fact, I'll have her contact you if there are specific, I realize they can just go on and
yeah,
mylimedata.org and fill it
yeah,
out. But if there are specific questions you even want them to answer
yeah.
on the My Lyme data, you should let me
Uh-huh.
know before I send out a blast. And hopefully I'll get you enough patients even from our practice.
Oh, yeah, we definitely want them to answer the antibiotic questions. So, I mean, the bottom line is we need for them to answer the full bank of questions. It doesn't take that long, but it's important because you can't do your subgroup analysis unless you know when were you diagnosed? Were you previously misdiagnosed? Did you have a positive Western blot? Did you have a rash? You actually need to know that information in order to be able to do things like say, how is this group different than that group to identify your
Mhm.
subgroups?
Right. Now, apart from the antibiotics that you are finding effective in the longer term, even if it's,
Uh,
doxy, because
uh,
Monica Embers, the study she just published
yeah,
last year, of course, doxycycline alone was not enough to eliminate Borrelia in the mouse. But if you
right.
used rifampin dapsone, two persister drugs, it did eliminate it, which is great for me because now when I go to the NIH for, the trials, I can say,
Mhm.
I have an animal model, I have a culture model, I have retrospective, so I mean, we'll
Yeah.
see. What other
Monica's done great research.
yeah, no, really fabulous. What
Yeah.
what other alternative therapies have people found helpful in the My Lyme data research?
Well, people have found using antimicrobials, so herbal supplements seem to be effective. And the other thing that we're seeing a lot of is there were a number of people who tried, this did not work very well, who tried stem cells. And stem cells, only 3% said that they were effective. So, but we were able to look at both the side effects and the efficacy of different alternative treatments. We've gone back in and we've beefed up that section since then to ask about specific herbal supplements because I think, a little bit the devil is in the details, in terms of which supplement were you taking, what was the effect that it was having. And but that's information that we've gathered a lot of, and we need to go back and do analysis of. I'm telling you, Rich, we have so much data. It's it's an embarrassment of riches. There's so many studies that it's like we sit there and we say, oh yeah, well, we have to do that study. We have to do that study. We need to do that study. Oh yeah, that brings up another study. It's great. It's
Would
really
it help?
terrific that the patients are making this happen.
Right. So it's not so obviously getting more patients to sign up. Again,
Yes,
mylimedata.org is where they're signing up for this, right?
yes,
But apart from getting patients to sign up, will eventually, like clinicians like myself, be able to go to the AI and ask a question? I mean, this would be the ideal, right? Go to the
right,
data, ask the computer. It's like I have just like right now, I got my new iPhone 16 with AI on it, right? So
right,
I'm
right.
using I'm using the Gemini from Google and I'm asking, and it's fun to ask it.
Yeah,
Will
yeah.
eventually, we might eventually have that ability as clinicians to ask questions from the data bank.
Yeah, wouldn't that be great? Wouldn't that be great? You have to know ground truth before you start, allowing sort of little questions because and you have to know what a question can answer and what its limitations are. So in order to train AI, I mean, we are working with somebody on AI, but in order to train that AI to do something like that effectively, that's years away. But it's not off the table because, AI is just growing exponentially. I mean, we use it quite a bit too. It's
Yeah.
it's extremely helpful in certain aspects. I wouldn't use it as a primary source for some things, but for other things, it's just extraordinarily helpful. But you
Yeah.
have to read it carefully.
I mean, where it's been helpful from my perspective is like doing PubMed searches and stuff and having it bring out like multiple scientific articles at once and adding. That's been very helpful.
Yeah,
Yeah.
right. Well, there's some really great tools for that we
Yeah.
could talk about.
So what's your next steps for the My Lab Data project? We're actually, I knew we were going to come to an hour almost
Yeah,
before we knew it. Then what are the next steps and anything else, by the way, you feel important that you'd like to share with the audience?
well, we're in the process of developing a comprehensive treatment survey. We think it's just really, really important to know what patients are using and what's working. And so that's going to be, what we're queuing up is sort of our next survey is going to be a really in-depth focus on treatments and treatment response and treatment side effects. We're interested in collaborating with clinicians, like you mentioned, and we're also working on academic collaboration. So we're working with UCLA. We've worked with the University of Washington. We're excited about a new collaboration with Sherry Marvel at Johns Hopkins that we're beginning, and this is working with students, which when you're dealing with academic, a lot of this is working with students. And then we've spoken with researchers at Stanford, and we're hoping that relationship will develop further. So, there's a lot of opportunities for people to collaborate right now.
Yeah, as I said, I'm going to speak to Nicole Close, the statistician we're using for our trial, and I'm going to have her contact you about not only what questions to ask in the study, but also getting the data right, so we can all kind of combine the data and use it and have the AI take a look at subgroup analysis. I think that'll be fascinating.
Yeah, it'd be great.
Yeah, Lorraine, anything else you want to share with people that you think, or did we cover the big points you think?
We've covered the big points. I just want to say one last time, if you are a Lyme patient or you know somebody who's a Lyme patient, please make sure that they sign up for My Lyme Data. You can do that easily by going to mylymedata.org.
Right. And I would please encourage people who are listening. We did this last year, right, when we did the summit. And
Yes.
did you get a good response from some of the people?
Oh yeah, people love this.
Yeah. So again, I mean, we're looking, and because this is a worldwide, I mean, the CDC, when they talk about roughly 500,000 cases, but
Yeah,
then they come out later in the year and say, oh, by the way, the Medicare rates were 7 times higher. It's like, what are we talking? 3.5 million people a year. It's like, if you have 18,000 people and over 3 million are getting, it's like, hey, everybody, please sign
yeah,
up for mylymedata.org and let's get that data in there because the more data you have with big data, the faster we're going to have solutions for this.
yeah, that's right.
Lorraine, you're doing great work. You're doing
Well,
great
thank
work.
you.
I want to congratulate you on sticking with this, and I'm really happy you stuck with it because it's such an important project. And again, we'll encourage our patients and our practice to sign up and try and get you some of that data also.
No, I really appreciate it, Rich.
Yeah.
It's been great talking to you.
Yeah. So for those of you again who've been tuning in, my name is Dr. Richard Horowitz. I'm co-host of the Dr. Talk Healing Lyme Summit 2.0. We've been discussing My Lyme Data, the largest online patient registry for chronic Lyme disease. Lorraine Johnson's been running that project now for years, doing a great job with 8 publications, more than anyone's ever done in this. Please sign up for mylymedata.org. And again, stay tuned soon for your next episode of Healing Lyme. Thank you so much for joining us.